for the kind introduction. I think when I was asked to give this talk, I kind of reflected myself about my journey to become a cardiologist, and when I, looked at how my passion for cardiology started, I really started thinking, okay, I'm going to be a heart surgeon. I'm going to start operating on people. That was a young me, right? Trying to save lives by operating. Then when I came to medical school, then I really thought, I don't know if I want to open up somebody's chest and do this surgery. And, it seems kind of too much. Let me try minimally invasive. Then comes my clinical years of medical school. And then I came across this article, how to prevent or stop a heart attack before it happens. And I think that's when it really hit me that prevention is better than cure. And I think what I was passionate about all along was preventing illness. Yes, all along the way you learn how to cure the illness, but much rather the important aspect was the prevention. So, like I tell all my heart patients, 80% of the work is done by you guys, not me. I'm just doing my 20%. So let's learn a little bit about primary prevention today. It's it's something that has developed quite a bit. Like you can see, this article was from 2005, more than 20 years ago, and we started with what looked like the scan of the heart like that, to now AI generated plaque analysis, which actually predict how bad your coronary arteries are. So the computer predicts what your burden is. And we use AI in our practice every day, even before we put stents, before we image, after we stent. We use AI to our AI technology to our benefit. So this primary prevention started 20 years ago, and we have come a long way in 20 years, and I'm really excited for what the next 20 years are going to look like. But let's see what we can do to protect our heart early with stress, movement, nutrition, and prevention. I have no disclosures. For the presentation disclaimer, I think you all know that it's being recorded. Coming to coronary artery disease, I'm going to try to keep it as simple, plain language as possible. There may be a few slides about data, evidence-based, and I'm going to try to keep it as much evidence-based as possible. CAD is an end result of accumulation of atheromatous plaques in the walls of our coronary arteries. It's a leading cause of death. Despite COVID, it still remained the leading cause of death. And it presents as an MI or a heart attack, sudden cardiac death in about half the individuals with this pathology. And traditionally, it was always scored in the office. In the good old days, go to a primary doctor or your family doctor, and they ask you, your risk factors are A, B, and C, and you have family history, you probably have a higher risk. And that translated over the next few decades into a Framingham risk score, which again was only predicting about 60 to 65%, not detecting many individuals who do not have traditional risk factors. So we needed better. And hence, the ACC, or American College of Cardiology, came up with this ASCVD calculator. It was supposed to be this new calculator which gave us an estimate. But then it had some, things which were not okay about it. It required external validation. Risk was overestimated. It had a hard time discriminating low to high risk, and the subsets were unimpressive. And the criteria were kind of the same thing. So we just thought, okay, now we have low risk and high risk and intermediate risk based on this calculator. But what do we do with that information? I mean, how can we make the patients have fewer heart attacks with that information? And this is how it, translated. This study was smartly done to see how they were overestimating the actually observed atherosclerotic disease, even in the low risk patients. About 5 times higher was the expected ASCVD risk by these calculators. The actual incidence was 5 times lower. Even when we go across to the intermediate risk or 5% or more, still the same phenomena, 5 times overestimated. And this is sort of the process. I'm not going to go into the medical jargon on the other side, just the buzzwords to remember. It's a chronic inflammation. LDL is cholesterol deposition without adequate removal, HDL. It leads to stenosis or claudication of the heart, essentially heart pain, plaque rupture or thrombosis. Those are all the factors that are going in there. And eventually, this atherosclerosis calcifies. And calcification is nothing but atherosclerosis in the heart. And there is a association between the presence of coronary calcification and risk of events. Now, this particular thing on the side is more for medical student, how the lesions progress. But for you, pay attention to the decades. This is not something which happened overnight. It happens over decades. God's given us all young hearts with no plaque. And over the years, our habits, our risk factors, our genes kind of dictate how fast we progress from the first decade to the third decade to the fourth decade and hence on of atherosclerosis. And this is another way to look at the artery. Where can we catch this calcification? Pretty much right in the middle of the lesion, right around 25-30%. But then what does our traditional stress test do? It catches things when it's over 50%, 60%. It may be too late at that point or just enough time. So what we wanted to know, is there a tool to catch it early? And that's where the CT scan came into play. And now that CT scan has developed into a CT coronary angiogram with plaque analysis by AI and functional testing by AI. So we're able to identify things not only early on, but we're actually able to characterize what each of those lesions look like. Are they calcified? Are they non-calcified? And what is the effect of treatment going to be on those particular plaques within your coronary arteries? So that's the advancement in science we have now. But I want to pay attention just to the CT scan, which, notes calcification on your coronary arteries. And what we see is just the tip of the iceberg. What we don't see is all this fibrotic and lipid-rich particles in your coronary arteries that are only visible by intravascular ultrasound or, unfortunately, on autopsy when we check the pathology, right? So, but the tip of the iceberg gives us an idea of how big a problem we're dealing with. So that's the key to remember. What we're looking at is right above the level, but that's enough to give us an estimate of what may be happening below the surface. And this is how it looks. What is calcium? It's atherosclerosis. It's extensive in atherosclerotic arteries, and it's absent in normal vessel wall. And that's why it's a strong, independent predictor of adverse cardiovascular outcomes. And this is a good picture. When you see this picture, it gives you a lot more information than just a picture. It tells you what the problem is right there. And this is how it's done. By the way, it's done here in Unity Point. They do it throughout the year. A coronary CT calcium score is done throughout the year. And they have the advanced CT scanner over here, 256 slice. And it has all the benefits that you need. It's a simple test. But what was traditionally the problem in imaging the heart was heart is beating. Obviously, we hope it's beating. And the beats are fast movements. So the coronary arteries move a distance several times their diameter for each beat. And hence it was, kind of difficult. But then we had the technology to develop our CTs from electron beam multi-detector. And eventually now we're up to the photon counting that helps us even identify plaque at a very, 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 very microcellular level. So We have more and more technology coming up. And what's the test procedure? It's a simple test, no preparation, no medications, and anybody can get it. Anybody in 40 to 80 group can get it. If you want to get it even after you're 80, be my guest. You want to get it before you're 40, be my guest. Where? Unity Point. And I believe it's $90. So patient lies in the CT scanner for about 10 minutes, must hold the breath between for 10, 30 seconds. Recently, one patient told me, I was in at 45 past 1 and I was out before 2. I was in my car before 2. It's like, that's great. 10 minutes and you get a scorecard and you're done. That's your report card. Medicare does cover it. There's a copay, I think, less than $50, as compared to a mammogram, which has a copay of $100, or a colonoscopy, more so, which has a copay of $500. Now, why did I mention these two? Mammogram, you all know, is for breast cancer screening. Colonoscopy is for colon cancer screening. Coronary artery calcium score is for coronary artery disease screening, period. That's it. And simple test, half the price, 1/10 the price of a colonoscopy, but big impact. Breast cancer, very high mortality in women. Colon cancer, very high mortality in men and women. Coronary artery disease, #1 killer across the globe, men, women, young people, old people. Radiation exposure is not much. Again, we're getting better with the CAT scan. Very low risk. I would say average yearly background exposure is 3 millisieverts. This test has now gotten better where we're doing it at 1.5 millisieverts. So half that, you know. In as compared to all the diagnostic CATs we did today, 4 of them I did this morning, 4.5 millisieverts. That's a lot. Mammogram, again, low risk of radiation, but gives you vital information. Just like that. So think about it, 3 mammograms, but 1 scan every 10 years. That's the key. 3 mammograms in 10 years equal to 1 coronary artery calcium score in 10 years. So you're not getting that much radiation. What kind of scores do you get? Well, it's measured in gastron scores based on the area and density. And typically your report will include a score for each major artery, the total score, and it'll give you some images, just like this. And in multiple studies, these definitions have been validated. 0 is the best score. This is the one test you want to get a 0. 1 to 99 is mild. 100 to 399 is moderate. And over 400 is severe. I think you have a question.
How often do you do this test?
Well, we'll go over it. If you're 0, your warranty is pretty good, and I'll tell you what your warranty is. But if you're mild, moderate, or severe, then you have some follow-up steps, and we'll discuss that. And you can see for yourself, this does not take anybody to guess that this is not normal. And that's the key to understand. When you get a report and you get your images, you can see for yourself what's normal and what's not. It's right in front of your eyes. And how does it help predict your cardiac events? A score of 0, annual event rate, very, very low. A score of 100, annual event rate, already up to 2%. And how does that correlate in form of coronary events, myocardial infarction, or sudden cardiac death? Again, relative risk 10% or higher. So that is the key to understand when to be concerned. As a practitioner, I know that anybody with a coronary artery calcium score of greater than 100 is higher risk as somebody less than 100. That's as simple as it is. Somebody who's more than 300, then you're starting to get in trouble. If you look at this data, mortality risk at 0, you're pretty good, almost all the way up to over 10 years, 10 and a half years to be exact. If you're 1 to 10, you're reasonably okay. You tend to live same pattern of time. 11 to 100, slight dip. 101 to 299, there's a drastic dip, especially around the 5-year mark. So those are the patients I would say, okay, in 5 years, you're definitely getting a CAC score again to see if it's better, stable, or worse. Somebody over 400, there's a markedly abnormal pattern going on there with mortality. And over 1,000 is definitely very, very, very poor survival as far as 10 years is concerned. Hence, those are the ones you identify early on, start doing what you can with primary prevention, find out what lesions are significant, treat the lesions before they become a heart attack. Okay? And again, validated in more studies, the MESA study, which came up with a beautiful calculator. And the same thing, if you have no calcium score or zero calcium score, your event rate or hazards ratio of MI or death from heart disease was very low. As your score went up, the hazards ratio went up. In the 10-year outcome done by Dr. Budoff, you can see the pattern. If you're over 300, your risk kind of goes up sharply in the beginning years itself. If you're over 100, yeah, maybe around the 5-year mark. But look at what happens with people who are 1 to 100. They're stable for majority of their decade. Right at the 10-year mark, there's an uptick in amount of atherosclerotic events or hard endpoints. But the people who are zero kind of zone off in that way where their event rate is not significant. So 0 is a good score. Anything over 0, kind of have to take care of yourself a little better. Again, warranty. We talked about warranty. So how good is this test, right? If you look at this particular study where they did calcium scores on everybody, about 42% had a calcium score of 0. So think about it, out of 10 adults, 6 of them may have had an abnormal calcium score, 4 of them had a 0, best in class, right? But out of that, only 48 deaths. So that's a pretty good, finding there, that very low risk of dying despite having a CAC score of 0. That's what you can tell yourself. But let's add in a caveat. If you have family history of coronary artery disease, then what? Well, we kind of split the curves of people who are a calcium score of 0 with or without family history of coronary artery disease. You still had a pretty reasonable survival rate at 10 years and 15 years. I saw a question there.
I was wondering what age range they were looking at in these studies.
Yeah, so the calcium score is only for people between 40 and 79. In the clinical trials, they did look only between 40 and 79. And that's how the indication also was only approved for 40 to 79. But can you get score earlier? Yes, you can. Can you get later? Yes, you can. Insurance may not cover it, but Unity Point will. Flat price, I believe. That's what I was told. And what do we do with the score, and how does it help patients? Well, traditionally, if you're a 40-year-old to a 79-year-old, with all the things that life puts on you, all the stressors, all the genes that you have inherited, you tend to land somewhere between low risk and high risk. So all of us are in low risk or high risk, or in between. Now, for people who are in between, how does this test help? Well, you can be reclassified as low risk based on a calcium score of 0. So if your risk traditionally with the calculator, which you can go home, open up MESA or ACC, ASCVD, put in your numbers, put in your lab values if you have them handy, and you calculate your risk. And if your risk says your intermediate risk, there's a wide range, 5% to 20%, then you should wonder, well, if I have a calcium score of 0, will I be reclassified to my risk being under 5%? Well, that's what the calcium score does. That's the information the calcium score gives you. So it not only helps with primary prevention strategies, interventions, but it also helps reclassify your risk, which the traditional general practitioner, family doctors, us before 2005, We did not have that. We would just label somebody low risk, high risk, or intermediate risk if you don't know if you're low or high. So that's the advantage of using the calcium score. And you see how many people of those intermediate risk kind of drop down to the low risk. That's the benefit. A lot of times, this has happened over and over again, decades. Every 5 years, the rhetoric about aspirin changes. Aspirin for intermediate risk, no data. But if you become low risk, guess what? Maybe you don't need aspirin. So those are some of the decisions that you can make based on reclassifying yourself. There are certain people who are in the intermediate risk were reclassified as high risk. And those are the people we caught heart attacks happening, or prevented a heart attack from happening. So that's the kind of information a calcium score will give you. What else does calcium score do? A picture is worth 1,000 words. It can help motivate patients to stay on top of their statins, weight loss goals, blood pressure goals, diabetes goals. If you have a report card which shows your heart in a picture and you see the calcium, you know that this is serious. If you have a report card which shows no calcium and you're doing well, your blood pressure is good, your cholesterol is under control, your diabetes is, you're not diabetic, and you're exercising, walking, you know you're in good shape. So that's what the calcium score gives you. It's an additional benefit to help motivate patients. And they tested this in a nice randomized trial where they took these middle-aged patients, about 2,000 and odd of them, with risk factors without CAD. And again, age range 45 to 75 without coronary artery disease. Scan versus no scan. No scan people got the clinical evaluation questionnaire risk factor consultation just like you would the past. The scan people got additionally the scan and scan consultation. And what did they notice? Look at the drastic change. LDL dropped by 30% or higher, or 3 times or higher, 3 times or higher. Change in systolic blood pressure, 2 times or higher, better than the no scan folks. Exercise, half of them started exercising more than 1/3 of them in the no scan. New treatment options, look at that uptick. And everything was statistically significant. The most important thing is adherence to the lipid lowering strategy. Whatever strategy you've chosen, people were more inclined to stay adherent to their lipid lowering therapy with a scan. So a scan is worth 1,000 words because you can motivate patients to take all of this in control in their hand. Remember what I said, 80% is what you do at home. 20% is what we give in the office, treatment in the hospital. And that's how it made it to the 2018 guidelines, the calcium score. For who? A class 2A indication for intermediate select borderline risk patients where a decision to use statin remains uncertain. Calcium score is reasonable to whether to start, withhold, or postpone statin therapy. And then they also found it helpful to make certain treatment decisions. Like if your calcium score is 0, it's reasonable to withhold therapy and reassess in 5-10 years for another scan, as long as higher risk conditions are absent. So if you're a young patient and your score is 0, there's no reason to take statin. If you're an elderly patient with no risk factors and your calcium score is 0, reassess in 5 years, stop your statin. I am sure you all are surprised a cardiologist telling to stop statin. Well, it is true. It's evidence-based medicine. But if you are diabetic, you better not stop your statin. If you have family history of premature coronary artery disease, you better take care of that risk factor. Cigarette smoking, definitely. And if your calcium score is even 1 to 99, as you can see in the previous slides, there's a slight uptick in events. So if you don't modify your risk factors, don't initiate statin therapy, then you're not doing the right thing. If your CAC score is high or you're more than 75th percentile, definitely statin is indicated. What else did calcium score make the guideline? They made the guidelines in 2021 chest pain. All the low-risk patients coming to the ER or to an office, general cardiology, primary care office, family medicine doctors, if they are stable chest pain with no known CAD, calcium score is now first line for excluding calcific plaque. 2A indication again. For intermediate high-risk patients, apart from the stress test, adding on a calcium score gives you more value, more chance to treat the problem even before it propagates. And who are these low-risk patients? I mean, 30-day risk of MACE based on our scoring. When a patient comes in, TIMI scoring, whatever scoring you use, heart score, less than 1% risk of atherosclerotic coronary events. No testing is necessary in the ED or outpatient. Previous guidelines would recommend within 72 hours, get a stress test. But that's no longer recommended in the 2021 guidelines, chest pain guidelines, and moving forward. What's recommended is shared decision making. Mr. Smith, these are your results. You do not have an acute coronary syndrome. Your risk is low. I would not recommend admission or further testing while you're here. I would say get an outpatient calcium score and reclassify yourself. If your score is 0, you're truly low risk. If your score is over 400, you get reclassified as to the next grade of risk. You initiate statin therapy, aspirin therapy, primary prevention. If your score is really high, get a stress test. That's what shared decision making is. Having the discussion with the patient deciding what's best for them, not the doctor deciding what's the next thing that they want to order, like a stress test from the ER. What else did 2021 chest pain guidelines recommend? Adding calcium score to stress testing made it valuable. More than half the times a normal stress test, people still have calcium scores of over 100. So in the past, practice was normal stress test, stop aspirin, stop everything, go home, you're fine. No, that's not the right way of looking at it. Half the patients with normal stress tests still have coronary artery calcifications or atherosclerosis at a very low level, and hence need to be still taken care of with primary prevention strategies. In low-risk patients, stable chest pain, high negative predictive value for a score of 0 is good. Those are the ones who stop everything and send them home, or stop everything and give them reassurance, especially the statins and aspirin. But a positive calcium score may need further testing, and that's an opportunity to initiate, intensify whatever therapy you're on. Preventative therapies are recommended for all patients, regardless whether they're obstructive, non-obstructive, stable, or acute chest pain patients. So some of the top indications: intermediate risk patients with 5 to 20% risk based on calculator, or if their risk is uncertain, family history, if they're reluctant or intolerant to statin, this would be a good way to give them that picture. This is why you need lipid lowering or primary prevention strategies. And again, we have non-statin adjunctive therapies like PCSK9 inhibitors or icosapentaethyls. Aspirin therapy is a big one. Motivation, again, to exercise more, control their blood pressure. And in the low-risk chest pain patients based on the 2021 guidelines. And this is how the MESA calculator looks, because it adds on calcium score to your traditional calculator, which the ACC validated. And the step number 1, you can do this at home too. Use your MESA calculator to give an estimate of calcium score by age, gender, and ethnicity. And then you get a 10-year risk with your coronary artery calcification, if you know your total cholesterol, HDL, blood pressure, and if you're taking medicines or not. And this is how a calcium score estimate impacts. Calcium score of 0, your risk is 3.1%. You don't need anything. Your calcium score is 276. Remember, it's in the middle zone, maybe medium risk. But by a MESA calculator, 13.7%. Again, intermediate risk. What do we do for that? Added a statin, aspirin, blood pressure was a little bit off, so maybe have an opportunity to treat the blood pressure. So that's the impact of calcium score on your risk. You should be cautious in using it younger patients. Again, 40 is the cutoff. If you're less than 40, be cautious. Unless you have dialysis or early onset diabetes, familiar hyperlipidemia, or extreme family history, try not to order a calcium score in those, is the general caution. And another big caveat, if you see a score of over 1,000, don't rush them to the angiogram suite, okay? If they're asymptomatic, the yield is low, and intervention may not improve outcomes. As an interventional cardiologist, I can tell you, stents work only for chest pain, heart attack, preventing damage, or preventing an unstable plaque from becoming into a heart attack. That's all stents treat. Primary prevention treats everything else. Now, this is something interesting I found in the Chinese medical text. Unfortunately, I started out my journey or my passion to become a doctor as an inferior doctor, trying to treat the full-blown disease. But I've learned through my years, at least to be a mediocre doctor, treating the disease before it's evident, like the calcium, coronary calcium. And I hope to be a superior doctor one day and prevent the disease altogether. So let's talk about primary prevention strategies. I think this play a very important role. I want to spend the rest of the time on this. There's some posters around the room that you can take pictures on your phone if you have, or there's a website you can scan. You can log in from your house on that CardioSmart, and you can go over these slides over there too. How do we stop heart disease before it starts? Because we know the problem. Heart disease will affect 1 in 2 adults, and most of the time, healthy habits can prevent it. What you can do is build a strong foundation, right? Foundation for your heart. Eat heart healthy, move more, maintain a healthy weight, avoid tobacco, manage your cholesterol, monitor blood pressure, and control diabetes. These are the steps that you can do. And more important than anything, you have to have a team-based approach. And these are all evidence-based. All these slides I wanted to put up because I wanted to show you where the evidence is coming from. These are all guidelines and recommendations made by the American Heart Association, American College of Cardiology. I know a lot of the jargon is over here. It looks busy in the further slides too, but I wanted to pay attention. Shared decision making is the real thing. Patient and physician decide together. Physician don't decide alone. This is the key, okay? And then always find out about social determinants of health. What can you do? As physicians, we need to ask all these questions. Adults should be routinely assessed for psychosocial stressors, provided appropriate counseling. I see some nurses in the audience. I see the rehab director. I mean, these are all the things that we need to assess and provide young people with health literacy every 4 to 6 years. Talk about diet, in addition to just saying what diet you need to do, uh, also find out about body size perception, social and cultural influences, and they all should be assessed. Then think about the potential barriers to a heart healthy diet, including, do they have food access? Are there any economic factors that they can, their vulnerable population, especially the elderly, and whether they're residing in socioeconomically disadvantaged areas of the city. So these are some of the things that we as practitioners in the medical team need to question or ask or find out or be inquisitive about during our encounters. Not just telling them to exercise, but find out where they are, neighborhood, environment, whether they have access to the physical activity that should be assessed. Not just counseling them about weight loss, but finding out what interventions and sleep hygiene, any stressors and other individual barriers are. And then weight maintenance should be promoted. Even if they are unable to achieve their goals, be their personal coach. Egg on or tell them you did a good job by maintaining your weight. That's the key. When you look at a number, give them their fair share of success just for maintaining the weight, even if they don't lose the weight. That's the key. Same thing with diabetes. It's easy to write a prescription for a drug and say, take this and once or twice a day and be done. But spend some time about finding out why they're diabetic. Is there any environmental or psychosocial factors, depression, stress, self-efficacy, or social support lacking that needs to be addressed? That way you can have a better discussion about improving glycemic control and adherence to treatment together. Same thing with blood pressure. It's easy to prescribe a medication, takes less than 10 seconds. Even talking about side effects takes less than 10 seconds. But find out why they have high blood pressure. Some people just come and tell me, I just can't sleep more than 4 hours. Well, that's your big problem. Short sleep duration, less than 6 hours, and poor quality of sleep are associated with high blood pressure and should be considered. And then find out about other lifestyle habits that impact blood pressure. And access to a healthy, low sodium diet and viable exercise options should also be addressed. Same thing with tobacco. I mean, this was my pet peeve. As a fellow, I did a research study when patients are admitted with heart attack. When we counsel them, right after we put a stent, while they're still in their twilight zone, I used to tell them, you got to quit smoking. The next day, I walk in the room, I tell them what we did. Then I end with, you got to quit smoking. What can I do to help? You have to take the time and find out why they would want to go back and smoke. What are the interventions that will help? Because they're at their most vulnerable point after a heart attack. And guess what the research study showed? More patients quit smoking. And that's the key. I think social support is another potential determinant. So everyone should always talk about smoking cessation every one of their visits. All the nurses, when they get chance. Our cath lab nurses do it routinely. Our rehab nurses do it routinely. So that's part of the guideline. That's what we are supposed to do. That's evidence-based. What about moving and stressors? I think one thing COVID did to all of us is socially isolate us, made us more anxious, and forgot to take care of us, the me time. So, all my patients, I tell them every day, take 15 minutes of your time just for you. Even if you're working, even if you're at home, even if you're, in space, just take 15 minutes. I would want you to just do what you like to do. Take a deep breath or just focus on a point, meditate, do an exercise or yoga, listen to white noise, the waves crashing in the ocean on YouTube, whatever you want to do, just do what you want to do. Turn off the phone or social media. Try not to be distracted. Take deep breaths. The biggest factor why COVID was so terrible was we all forgot to take deep breaths. Expand the lungs. Lungs are supposed to be expanded. They're like balloons. You have to keep expanding them. So if you don't take deep breaths, then you're not doing any good for your lung health. So being mindful, this is called self-mindedness. Being physically active and finding ways to reduce stress can help and prevent or manage heart disease. Try to sit less, move throughout the day, even in small amounts, is good for your health. Staying active supports a stronger heart, improves circulation, lifts mood and self esteem, promotes sleep, lowers blood pressure, cholesterol, and sugar, decreases the need for medications, helps manage your weight, and reduces stress. And these are some of the stress mitigation strategies: breathing exercises, peaceful thinking and meditation, muscle relaxation exercises or yoga, and soothing music just helps too. Or just taking part in social groups, this also, or support groups, this also helps. And moderate activity can just be as simple as just taking a brisk walk, gardening, if you like gardening, or just doing household chores such as vacuuming, or just dancing. dancing is a mood elevator. Just dancing could be a good moderate activity. Traditionally, all angiograms were done through the groin, so patients wouldn't be able to dance right away. But nowadays, we do it through the wrist, right? So I tell all my patients, hey, I went in your wrist, so maybe later the wife or husband can take you for dancing. So that just is a mood elevator, a laser wrist. And again, what are we supposed to do with the risk assessment? You all can do it at home. Your primary doctor, cardiologist, everyone has to assess your risk. It's recommended class 1. Um, Again, there's a whole bunch of intermediate risk, borderline risk, when to use coronary artery calcium score. All of these recommendations are there in our guidelines too. And then important thing to remember, not just the traditional risk factors, but the risk enhancing factors. If you have a family history of premature coronary artery disease described as somebody who's less than 55 for a male or 65 for a female, that's premature coronary artery disease. You should be getting a calcium score and getting your risk assessed. Primary hypercholesterolemia, LDL more than 160, or a non-HDL more than 190. And then the newer kids on the block, the elevated high sensitivity CRP, elevated lipoprotein little a, which is a very strong indicator of premature coronary artery disease, elevated apolipoprotein B. Those are very, very, very important to make a diagnosis of FH or familial hyperlipidemia. Okay. Metabolic syndrome, if you have an increased waist circumference, elevated triglycerides more than 150, blood pressure is high, elevated glucose, and low HDL, you just need 3 of these to make the diagnosis. Okay, so that's also a risk enhancing factor. Chronic kidney disease in itself is also a risk enhancing factor. Inflammatory conditions like psoriasis, rheumatoid arthritis, lupus, or HIV, risk enhancing factor as well. If you have premature menopause before 40, or if you have pregnancy associated conditions like preeclampsia, you also have a risk enhancing factor. South Asian ancestry is a risk enhancing factor. And then if you have an ABI or a circulation test which is abnormal, that's a risk enhancing factor. We have now the good news about the cholesterol, elevated lipoprotein. We have things in the pipeline that are specifically directed and targeted towards that. So we're able to treat young people with elevated lipoprotein A before they have a coronary event as part of new therapies. Same thing, elevated apolipoprotein B is just as equivalent to an elevated triglyceride or an LDL, but it is an independent risk factor. So just don't stop at looking at LDL and non-HDL and forget about these other risk factors which are silently brewing in the back, which can be teased out by, your primary doctor, your family doctor, or your general cardiologist. Nutrition and diet. I want to spend some time here. It is class 1 to consume a diet which emphasizes intake of vegetables, fruits, legumes, nuts, whole grains, and fish to decrease atherosclerotic disease. Focus on what is mentioned as class 1. Then, replacing your saturated fats with MUFAs or PUFAs, monounsaturated, polyunsaturated fatty acids, can be beneficial. And avoid trans fats, class 3. Trans fats are harmful. So your homework for today, everything you buy in grocery store, look for trans fats, put it back. Saturated fats are high, put it back. Monounsaturated, polyunsaturated, buy it. MUFAs, PUFAs, buy it. That's as simple as it can be, right? Same thing I'll tell about sodium. Simple rule of 5. Look at the back of the nutritional contents, 5% or more sodium. No, thank you. Put it back in where it belongs. Low sodium, buy. Take the low sodium option if you have. It helps reduce your ASCVD risk. And then Minimize your intake of processed meat, refined carbohydrates, sweetened beverages to also reduce your risk. So these are some of the suggestions that the guidelines tell us to do. And this is a slide, again, you'll see across the room what you can do to protect your heart. Focus on the fruits, veggies, nuts, whole grains, and lean protein. And a healthy, heart healthy eating plan needs to be tailored to you. Each one of us come from different cultural backgrounds. Talk to your health professional or a dietitian and tailor it to what is normal for you and what you can do to pivot from the unhealthy towards the healthy. There's no magic diet which will cure all, but there are some diets which have come close or have data. So I'm not here to tell you which diet to do, but if Mediterranean diet is the closest one to what's normal for you, pick that because it's light on dairy, meats or sweets, and it's allows you to eat fish, olive oil, and even wine is okay in moderation, red wine. Uh, if you are in the vegetarian category, which cuts out all the meat, vegetable proteins, make sure you eat enough of soy proteins or legumes. And the vegan goes a little further with no meat, fish, eggs, or dairy products. There was one of the ACC presidents, Dr. Kim Williams, who's at Rush now. He was a big proponent of vegan diet, and he actually did a study. People who did vegan diet had lower events, lower cholesterols, lower blood pressure, lower waist circumference, and had less chance of becoming diabetics. And this is over 10-year data. 30-year data is far-fetched, but we'll see what happens in the next 20 years, as I was saying. Maybe vegan is the way to go. And 20 years from now, that probably will be the recommendation. And as part of the training, he told all his fellows at Rush to try vegan. And I think most of them did it because they were scared of him. but they all saw positive benefits. As a first-year fellow, every first-year fellow who did, by the end of their fellowship, they saw positive benefits in themselves. So Dr. Kim Williams is a strong proponent of vegan diet, which is whole food, plant-based eating, avoids the processed food. If you're somebody who likes numbers and can stick to a very strict diet, maybe the DASH diet is a good diet for you. It's a dietary approach to stop hypertension. Limit salt to less than 1.5. So the sodium amount that all of us hypertensives can have, 1.5 grams or lower. Even if it's not possible to do that for other reasons, at least lowering by a gram a day may be helpful for you. Try to consume lean meat, poultry, or fish as part of the DASH eating plan. Fruits and vegetables rich in potassium like bananas and leafy vegetables. And more tips could be just cutting back on processed meat and saturated fats, avoiding trans fats, and drinking water instead of soda. What about exercise? I think we all know this. I mean, everyone should tell all their patients about exercise on every visit. What do we do? 150 minutes of moderate intensity or 75 minutes of vigorous. And I'll define. And even if you're not able to do a moderate intensity, any activity that you do will yield benefit to reduce ASCVD. So don't be disheartened if you're not able to brisk walk, if you're not able to dance, if you're not able to do any of the moderate intensity category. The key is to decrease sedentary behavior. And if you look at what are the 6 ways of physical activity that will benefit your heart, strengthens your heart muscle, lowers your risk of heart attack and stroke, improves cholesterol, lowers your blood pressure, helps control weight and blood sugar, and boosts mood, promotes sleep, reduces stress and inflammation. And move more for a healthier heart. Sit less, take more steps, get your heart pumping with 150 minutes of activity a week, and add muscle strengthening the other 2 days. If you're doing 30 minutes 5 times a week, the other 2 days, all my patients get that same homework. Do a little bit of weight training or resistance training, and that'll help up with the protein and the muscle. And this is what we mean by moderate intensity. A brisk walking, biking, ballroom dancing, active yoga, recreational swimming. But if you want vigorous activity, you're in the jogging, running, biking, singles tennis, or swimming laps category. But if you look at what's disheartening is US adults spend more than 7 hours a day in sedentary habits, sitting, reclining, lying, watching television. Um, that's a problem. Even if you can convert a little bit of that time towards moderate intensity exercise, or even if you do a little bit light activity like walking slowly, cooking, or light housework, that'll yield positive benefits. What about overweight and obesity? Again, BMI calculation is a must for everyone at every visit. And talking to them about it is also important. And weight loss is recommended for both overweight and obese individuals to improve their ASCVD risk. And lifestyle interventions, calorie restrictions, maintaining the weight loss, these are all counseling strategies that we should do. And sometimes just measuring waist circumference will give them a clue that if my waist circumference is more than half of my height, then I'm in trouble. I better do something about it. And that's the key. It mentions over here waist to height ratio. Why does weight matter? Weight matters when it comes to your heart and overall health. More than 2 out of 5 adults in the US have obesity, and it can be treated. Um, what are the risks? Heart risks, high blood pressure, cholesterol, diabetes, depression, sleep apnea, CAD, heart failure, heart rhythm problems. Number one cause or top 3 cause in the world, including United States, is obesity. Heart attack and stroke, obviously, we know that. BMI is a number which you get. You're overweight if your BMI is 25 to 29, obese 30 or higher. Waist circumference is important. What can you do if you're obese or overweight? Increase your activity, eat fewer and better calories, get enough sleep, consider seeing a dietitian or joining a weight loss program, and try a weight loss medicine if you want. That's in conjunction with your primary doctor and endocrinologist. And bariatric surgery is reserved for a very minimal number of patients, but it has yielded positive benefit. Losing weight is hard, but get the support you need is the key. Diabetes, again, there's a lot of recommendations, a lot of class 1, a lot of medicines, but again, start with heart healthy diet, exercise, then go to medicine. That's the key. If you see what's indicated as class 1, start with heart healthy diet, weight loss, exercise, then comes medicine, then comes the weight loss medicine. So that's the key to identify. This is a simple pattern that runs through my mind when I treat my diabetic patients. Your A1C is over 6.5, you're considered diabetic. A1C 6.5 is diabetes, guys. You have to start with dietary counseling on all of those patients and then have them exercise 150 minutes. That's the first line treatment. Non-pharmacological treatment comes before pharmacological treatment. If your A1C remains less than 7 after therapy, great. Nothing to do, continue the therapy. But if they have poor control, then medicines come into fray. Okay. Metformin can be considered first line to improve glycemic control and reduce cardiovascular disease. But more importantly, the newer weight loss agents are a class B and can be considered as a second line agent on top of metformin. So if you're not on metformin, should be on metformin first before you go to the newer agents, is what the current recommendation is. Again, cholesterol guidelines, busy slide, tells a lot about what needs to be done, what are the categories where you start a statin. It almost seems like everybody gets a statin. It's so busy, my eyes are hurting. But it can be simplified. Again, the same pattern: diet, exercise, then medicines. But who gets the statin is understanding the key aspect in this. And it's easy to kind of break this down. Look at the right side of your screen or my screen. You start with the age groups. If you're very young, less than 20, and you have a diagnosis of familial hypercholesterolemia, then you get a statin. If you're 20 to 39, then you estimate your risk. Consider statin only if you have a family history of premature coronary artery disease or LDL is over 160. Now, if you're in 40 to 75, which majority of the population are on statins, then you have several factors. Your LDL needs to be 70 to 190 without diabetes. Then you calculate ASCVD risk. If you're diabetic, you automatically get a moderate intensity statin class 1. If your LDL is over 190, you automatically get a statin that is high intensity statin. And if you're diabetic with age group in this, you can consider optimizing your moderate intensity to high intensity if you're not achieving your goal. And if you're over 75, clinical risk assessment is important, risk discussion is important. Use calcium score to your benefit. For the low risk patients, no statin, just lifestyle changes. Borderline risk, you can consider if you introduce your calcium score in there. Intermediate risk, if you have any risk enhancing factors, considering moderate intensity, use calcium score to the benefit. High risk, initiate a statin therapy and look for reduction in LDL. The goal is not to be stuck on that number 70 or lower. The goal is to be 50% reduction or higher if you're at high risk. If you're at intermediate risk, the goal risk reduction is 30% or higher. Previously, all the guidelines were asking us to be stuck on a number. We no longer use the number. We use the risk reduction, percentage reduction in your LDL as a guideline, whether to intensify treatment, withhold further intensification, or lower your statin therapy. Same thing with blood pressure. Busy slide talks a lot about medicine, chronic kidney disease, but look at again what's class 1 and top of the line. Weight loss, non-pharmacological intervention, heart healthy diet, sodium reduction, dietary potassium supplementation, increase your physical activity or exercise, limit alcohol. And then if you do have a diagnosis of high blood pressure despite that, which is defined by 130/80 or higher, then use the ASCVD calculation, risk calculator to your rescue. Again, 10% or lower, try just non-pharmacological therapy. 10% or higher, yes, pharmacological therapy. If you're diabetic or chronic kidney disease, your goal is still less than 130/80. This differs from before. If you're over 75, you don't get a pass. You still have the goal of 130/80 or less. And the reason I say it is based on the new clinical evidence. And this was a smart done trial where they tried lenient control versus strict control. And the lenient control group got elderly patients to be in 140 and above, and the strict control got it down to 120/80 or lower. And they noticed remarkable outcomes. They had fewer strokes, fewer heart attacks, and then fewer heart failure. So, to put it in numbers, amongst the cardiovascular patients of the Quad Cities, I don't know how many they are, but where we estimate about 100,000 patients out of the 400,000 population over here are cardiovascular patients. If all of those patients, amongst those, whoever is 75 or older, or in general, even if you're not 75, if we maintain a blood pressure goal of 120/80 or less, we could potentially save 1,000 people every year from getting a heart attack, stroke, or heart failure, or dying from heart disease. Let that sink in. 1,000 people will be saved in a year. And if we keep doing that over a decade, 10,000 people. So if our average drop every year is going to be 1%. Pretty soon, the longevity of Quad City population cardiovascular patients will be increased if we just stick to the strict blood pressure guideline. And that's the key for everyone to discuss. Lenient may be okay in some situations. Strict is okay in all situations. And this is kind of the pattern we follow, or is recommended to follow by the guideline. Normal blood pressure is less than 120/80. Promote healthy lifestyle. Elevated blood pressure is between 120 to 129. 80 to 89 is stage 1 hypertension. The top number is 130 to 139. Always start with non-pharmacological intervention as class 1. If their estimated risk is high, then go to BP lowering medicine. If they're stage 2 hypertension, you do a combination of both, not with one medicine, but with 2 medicines, because you're stage 2 hypertension. And if you look at why non-pharmacological intervention plays the key, remember what I said, 80% of treatment, primary prevention, is effective in all patients, with 20% done in the office. Look what these numbers are doing when you lose weight. You have about 5 millimeter decrease if you're a hypertensive. Healthy diet, 11 millimeter mercury. Some of the medicines do that. Reduced intake of dietary sodium, 5 to 6 millimeters of mercury by yourself. Dietary potassium increase to about 3.5 to 5 grams, 4 to 5. Physical activity, if you just stick to your 150 minutes a week, 5 to 8 by yourself. If you add on a little bit of resistance training, isometric training, simple dry weights, 1 pound, 2 pound, 15 minutes over the weekends, 5 millimeters of mercury by yourself. Resistance bands can also be used here. And if you just cut back on alcohol intake to less than 2 drinks for men and 1 drink for women daily, you will also see positive benefits of lowering your blood pressure. So this is the key. And those benefits not only in just hypertensive patients, but even in the normotensive patients. Even if you have a normal blood pressure, you do find benefit for all of this. So this talk is not just for the people with risk factors, but also for the people who are normotensive. Tobacco abuse, again, as I said, my pet peeve, all patients should be assessed at every visit, and all adults should be firmly advised to quit if they're smoking. And find out why. Why is it hard? Probe into what you can do is the big key. If you have a friend, just talk to, why is it so hard for you to quit smoking? Let's talk about that. Let's address the elephant in the room and see what you can do to help. Sometimes it's a simple scenario. Oh, I just need to smoke after I have food or after this particular behavior. Well, why don't you take a Nicorette gum or a lozenge? A simple thing. You got to trick your mind. Oh, I just have to smoke after I wake up and brush my teeth. Well, why don't you just have a lozenge or a gum as soon as you brush your teeth? Simple solution to a complex problem. Secondhand smoke should be avoided by everybody. And yeah, the drugs and the patches, I think we don't need to pay much attention to this, but if you're somebody who smokes more than 10 cigarettes, you can try a patch, 21, or if it's less than 10, 14. Gum lozenge works. If you're, again, waking up and less than 30 minutes, you have to smoke your first cigarette, try the gum at the higher dose or the lozenge at the higher dose. I don't have much data about nasal spray or oral inhaler. Pulmonologists will tell you it may be available. And the medicines, the black box warning has gone out. So the FDA has removed the black box warnings about neuropsychiatric events. Always use it under the guidance of your primary doctor or family doctor is what I would tell you if you're using Wellbutrin or Chantix. Why stop smoking? It harms nearly every organ in your body, including your heart. 1 out of 4 deaths are caused because of smoking from heart and vascular disease. harm to your heart by irregular heartbeats, thickened, narrowed blood vessels, plaque buildup in arteries. And quitting isn't easy, I know that, but it will give you your years back. So that's the key, finding out. And it can be forgiving. And when I say it's forgiving, I don't mean the cancer risk or the lungs, because once the damage is done, it's done. But the beautiful part about quitting is if your risk was 1 to 2 times to 1 to 4 times higher for heart attack and stroke, if you quit over the next year or two, your risk starts declining, almost as if you didn't ever smoke in your life. And that's the part. You get your life and your years back. That's the key to quit. And what are the tips to quit? Find a plan that's best for you. Set a date. And sometimes I have to tell my patients it's cheaper to take this medicine than buy your cigarette packet. So, and that's the truth, unfortunately. And it may help you live longer. Remind the patients why you're quitting. Avoid activities or places that make you want to smoke, and make it public. Tell your friends, tell your family, I want to stop smoking and I don't want you to smoke around me. Please leave the room, or I myself will leave this room if you're smoking around me. And ask about programs that can help you quit. Take advantage of all these programs, 1-800-QUIT NOW, or this Cardio Smart website. And don't give up. And slips are common. If you fail, you get up and you try again. If you fail again, you get up and you try again. And you keep trying until you succeed. And that's what watching the Winter Olympics taught me. I don't know about you guys. And celebrate your small successes. And that's the key. Uh, Again, the big aspirin drama. Every 5 years, the rhetoric changes, and we have to go with what's evidence-based. If you look at, if your risk is very low on the right side of the screen, MESA study showed if your risk is low, you need to treat about 2,000 patients in order to get one benefit. That's a pretty high number for me. If your risk is high and your calcium score is 0, you still need to treat about 750 patients for one patient to benefit. Still not good enough. But if your risk is high, if your calcium score is high, then you do start noticing the number needed to treat is relatively in your favor, in your patient's favor. So that's the key, using calcium score to decide whether or not to use aspirin as primary prevention. Not everybody needs aspirin, but there are some folks who would definitely benefit from aspirin. Why aspirin's the bad boy? Well, you can see it on the screen. If you're low risk, causes more bleeding than benefits. So why would you want to use it? But if you're high risk, it sort of starts leveling out. So you kind of have to do this benefits versus risks. And again, 2B is a relatively lower spectrum recommendation for primary prevention. So not all patients will require aspirin, but a low dose aspirin might be considered for primary prevention among select adults 40 to 70 who are at higher risk and not increased risk of bleeding. But definitely don't give aspirin to elderly patients for primary prevention without calculating their cardiac risk on a routine basis, and definitely don't give them if they're at increased risk of bleeding. Okay, that's the key takeaway from this. And I think it aligns with the current US Task Force guidelines, so which is a good piece of information to know. Vaccination. I'm glad we're in a state where I don't have to worry about what I say about vaccines, but I'm going to try to stay in my lane and be politically correct. Vaccines do help protect your heart, and staying up to date is a good idea. Having heart disease makes you more likely to become seriously ill from infections like influenza, like the flu, COVID, and pneumonia. And these infections can strain your heart. I've seen this time and again. They can also lead to heart attack, heart damage, stroke, and even death. So make sure you're protected. Talk to your physician about getting vaccinated. Find out about vaccines before you commit. And it should be a shared decision making. Patient and physician decide together, not one-way street. Vaccines help prevent disease, make illnesses milder if you get sick, save lives, and keep other people healthy too. And make sure you're up to date with influenza, respiratory syncytial virus, pneumonia, shingles, Tdap, and hepatitis B. I purposefully skipped COVID just for political correctness. Depending on your age, lifestyle, you may need other vaccines too. So the top 10 take-home messages from today for primary prevention. The most important way to prevent atherosclerotic disease, heart failure, AFib, is to promote healthy lifestyle throughout your life. A team-based approach is important, and you have to probe into any social determinants. If that's one takeaway from today, if you can, always ask why not? What's the hindrance to practicing this? And I think that's the key. Okay. Adults who are 40 to 70, 10-year risk calculation, use the calcium score to benefit, and add on therapies like statins, aspirin, and be wary about certain risk enhancing things, factors. All adults, healthy diet, vegetables, fruits, nuts, whole grains, lean vegetables, lean protein, animal protein, fish, and minimize the intake of trans fats or red meat. I tell all my patients red meats are for anniversaries, special occasions, holidays. The rest of the time, lean white meat. Refined carbohydrates, sweetened beverages, be wary of that. Overweight or obese, always get your counseling about calorie restriction and try to achieve and maintain the weight loss. Physical activity, 150 minutes moderate intensity or 75 minutes vigorous activity, or do something. Just move. That's the key. Diabetes always starts with lifestyle changes, dietary habits, exercise, and then followed by metformin first line, newer weight loss injections, or oral pills second line. Every healthcare visit, smoking use should be addressed, and tobacco cessation should strongly be advised to quit. Aspirin, infrequently used in primary prevention. So the net benefit, remember about the net benefit versus risk, and a shared decision making between you and your provider. Statin therapy, first line treatment for anybody, ASCVD risk is high, intermediate, with elevated calcium score, or if they have elevated LDL over 190, diabetic, and in the young age group with high enough ASCVD risk. Non-pharmacological intervention is again the key for all patients with elevated blood pressure, those requiring pharmacological therapy, and the target is always 130 over 80 or less, irrespective of your age, irrespective if you have chronic kidney disease or diabetes. That's the key takeaway from today. My last slide is missing the presentation here for the Spurti run, which is going to happen on May 19th, I believe. So it's a fun run for anybody who just wants to walk, light walking, moderate intensity exercise, or vigorous exercise, whatever you want to do. There's some flyers over there. There's some representation from Spurti that you can talk about their goal and their mission and what they want to do. But important to remember, whoever saves one life saves the world entire. And with that, I want to end my primary prevention talk, and I'm open to questions.